I'm Chris Adams, Director of Training at the National Press Foundation. Our topic today is words, what they can mean and how they can be misused in a way that causes pain, particularly when it comes to the reporting of mental illness. I'm joined by Rebecca Palpant Shimkets, who runs a mental health journalism fellowship program at the Carter Center. In doing so, she sees hundreds of stories on mental and behavioral health. Too many of them lack an understanding of mental illness or use language that could further the stigma that often comes with it. How can journalists do a better job? She's got some suggestions for that, as well as specific guidelines that reporters can use. We'll talk about those guidelines as well as other resources available to journalists. And we'll be taking questions from our viewers. Tweet them at NatPress or submit via Facebook. Rebecca, welcome.
Thank you.
So we're here to talk about best practices for reporting on mental health and substance use disorders, what language is appropriate and what language is harmful, what appropriate approaches are interesting and informative for viewers and our listeners. So as I mentioned, we'll be taking questions. If you have one, send it a question for Rebecca, send it to us on Twitter at NatPress or via Facebook. But I want to start out talking about a news item from just last week. When we were preparing for this conversation, that was the day that the lead singer for the new metal rap group Linkin Park died. That was Chester Bennington. He committed suicide. Most of the stories that mentioned his suicide mentioned the cause of his, or the method of the suicide. Many of them I was mentioning it in the headline of it. That wasn't always the case. The New York Times story and obituary the next day just indicated the suicide was being investigated, but it didn't even mention the cause of death or the possible method. So what do you feel about stories that do mention the method of suicide? It's been a traditional practice in the media to do so. What do you think of that?
Well, first of all, I think we really need to understand, Chris, that this is a tragic incident, but it impacts so many people. I think everyone viewing this webinar or who will see it in months and years to come, each person has been impacted by suicide in some way. Either they know somebody who has completed suicide, or they've had contact with a family member or friend. So this is an issue that impacts everyone. I think we need to really emphasize that and point it out. In addition, it's a huge public health problem in this country. On the day that he completed suicide, 110 other people in the United States completed suicide. And so just for our viewers' purposes, I think it's important to draw the connection between that event and the fact that the vast majority of people who complete suicide have some kind of mental health or a substance use condition that is a part of that story. So then leading to this whole issue of, do we talk about the means and the way in which someone completes suicide? There are really clear standards now by many organizations, including the Carter Center Mental Health Program, that's really not relevant to the story to state that in a headline, to talk about the means by which someone completes suicide, if you really look at suicide as a public health problem and a health crisis. For example, look at any other health condition, any other health story where death is a part of it. Cause of death is a part of that story, but talking about the ways in which the person died really hardly ever becomes a part of that story. So I think we need to kind of pull back and think about these as health issues.
Okay, so the newsmen inside of me and other people in the news industry will say, well, that's a fact of what happened. It's news, it's out there, anybody can Google it and find out in 6 seconds how Chester Bennington died. And I think of big cultural icons, big cultural figures in the past. I know how Kurt Cobain died, I know how Ernest Hemingway died, both by suicides. A couple of years ago is a suicide by comedian and actor Robin Williams. So I think news traditionally has said this is a fact, we should be reporting it. Our viewers, our readers are interested in it. How do you respond to that?
It's true, readers are interested in it. And, I understand the need, and the interest in making that a part of the story. But I think we have to talk about contagion as a real issue. These are highly sensitive events, and I think this particular case in point is germane to this discussion. Chris Cornell, the very dear friend of the individual who completed suicide this past week, completed suicide just 2 months before in the same way. There are a lot of people dealing with pretty severe depression who often, when that's the case, are not thinking clearly, and having easy access to information about ways and means to do this can be highly damaging. And I think we need to think about the sensitivities around this. If you stop and think about how many people complete suicide, in a given year in the United States, it's equal to the number of women who die by breast cancer in a given year. Mm-hmm. And when we think about what we've done around breast cancer in this country and how we report about it, the importance of early intervention and prevention and screening and access to services, in no way would we ever really talk about the last moments and report on what that death looked like. It's just a matter of how they died.
Okay. So we're going to talk in a bit about journalists who have done it correctly. We're going to have some stories of journalists who reported on mental health issues in a way that was informative and interesting. But right now we're going to talk about some who didn't. So you shared some stories with us. These are some stories from the past. Some of these headlines are decades old, but some are just a few years old. So we're going to show some of these images. The first one from the New York tabloids: "Get the violent crazies off our streets. 1,200 killed by mental patients." Mm-hmm. What's your reaction when you see headlines like that?
First of all, my reaction is, I think overall we're doing a great job today.
Yeah.
When we have to dig up these kinds of headlines, we have to go back pretty far for something like this. So I think overall, journalists are to be commended for the kind of reporting that we're seeing now. There are still problems, but in looking at a headline specifically like that, my immediate reaction is, boy, did they get that wrong. Because what we know about violence, mass shootings, and mental illness, the line between the two is very thin. Only about 3% of violent acts in this country can be attributed to somebody with a mental illness. And in fact, you're 15 times more likely to be struck by lightning than to have a violent act perpetrated by somebody with schizophrenia or an active psychosis upon you. So, these are rare events, but headlines like that just try to drive home, I think, that there is some connection that really doesn't exist.
Okay. Now this next one, these next couple are dealing with the language usage. So this one, bonkers Bruno locked up and sad Bruno in mental home. What's your reaction to those?
Well, I think terms like bonkers, schizo, nuts, it really doesn't, first of all, they're insensitive to use at all, and certainly not something a journalist should even consider if they're reporting accurately and using the best kind of reporting techniques that they learned all the way back in school. I think also, and I think we'll look at a series of headlines like this in the next few minutes, but I think what they do a really good job of is beginning to isolate people who have the experience of mental illness and distance us from those people and labeling them as something different that we need to not interact with. And I think it sends a really wrong message. One, it's insensitive, but two, it pushes away from this whole notion that we all have mental health. Mm-hmm. Each one of us has mental health. And at times, we can become sick Other times we are more well. Some have chronic conditions. Others have, an isolated event of depression. And the same is the case for physical illnesses. But using insensitive terms like this that cause us to distance and isolate doesn't tell the story about mental health.
Okay. Now let's go on to, these are just a couple of years old. These are both from mass shootings. The first one involving the U.S. Representative Gabby Giffords. Jared Lochner is losing his fight to stay crazy. And a similar one from the theater shooting case. James Holmes might be crazy but not legally insane. What's your take on those?
So using words like crazy it certainly doesn't indicate that there is a mental health problem that can be treated and that people ultimately can recover and live meaningful lives in the community. We're working on kind of two polar opposites. You're either well or you're crazy, but there's nothing in between. And I think we need to step away from language like that. In addition, I think as journalists, and I'm not a journalist myself, I just work with a lot of journalists, and on their reporting and on significant projects related to mental health. But I think we need to be more sophisticated about how we talk about mental health. There are specific diagnoses in mental health, like schizophrenia, like bipolar disorder, like major depressive disorder and PTSD. And we need to really start educating ourselves about what those illnesses are, what the symptoms are, and use them properly and have the right experts and people with a lived experience involved in ensuring that when we use those, it has been diagnosed appropriately and it is a part of the story. So just saying someone's schizo or psycho, one, there's not really a diagnosis using those terms, but two, it doesn't do justice to a whole body of work around diagnosis of mental illness.
Okay, so we actually have another headline using that schizo term. ETV criminal is schizo, that's according to the court. So again, just using those terms don't add much to the story, right?
They don't add much to the story because schizo is not an accurate diagnosis. I think whenever journalists determine that a diagnosis is relevant to a story, it's very important to do the level of reporting and research necessary to determine if it is indeed relevant and there is an accurate diagnosis involved.
Okay, and now just a couple more here we want to show our viewers. This one is one of the more offensive ones that you came across. The headline from the Trentonian newspaper, roasted nuts, on a headline about a fire at a psychiatric hospital. I was doing some research on this headline, and I read that the editor who approved it, let it go through, felt horribly about it. He realized a huge mistake he made. He apologized for it profusely, but it was stuck with him the rest of his career until he died. But what is a headline like that? I mean, how do you react to that headline?
Well, that was years ago. And as I said earlier, we have made tremendous progress in terms of headlines, how we talk about mental health. But I think it points out something that is very current that we need to talk about as a part of this conversation, and that is using sensational headlines to drive viewers, readers to a story. In our 24/7 news cycle with social media, headlines have never been more important. And clickbait is real. And there is a huge amount of pressure to get people to click on something and to appeal to our most kind of basic inclinations. I think we really need to take a step back and see, what are we doing here? Are we really contributing to the stigma and discrimination associated with a public health condition? Or are we stepping back and saying, you know what, we have an important job to do here. we need to ensure that what we're doing is sensitive, balanced, and professional.
Okay, and finally we want to show, this has gone way, way back. This is from 130 years ago from the, I think it's the Wheeling, West Virginia newspaper, called A Case of Suicide. You sent this to me. What's your take on this particular little blurb about somebody's death?
I sent it to you because I think sometimes in discussions like this, we tend to focus on the most immediate. And I think, I just wanted to point out that the stigma and discrimination around mental illness has been around for a very long time, hundreds, if not thousands of years. We've made a lot of progress, especially over the last few decades, on a number of social conditions. Progress has been extremely slow in this area, as exhibited by, going all the way back to, the 1800s, very, very discriminatory, but two, I think the other thing I wanted to point out with that is the level of detail with which they describe this suicide. I think, we can definitely say, I don't think you would see that level of detail today. So progress has been made on a very, very old problem, but we still have a lot of work to do.
Okay. So I just want to remind our viewers that if you want to send a question in for Rebecca, tweet it at NatPress or submit it via Facebook. So let's talk a little bit more in detail about why all this matters. And a big part of that is the stigma attached to mental health, mental illness. Can you maybe talk a little bit, first of all, I have a couple of definitions of stigma, and I was hoping you could kind of elaborate on these quotes. One is from Otto Wall, Dr. Otto Wall. Stigma is a mark or label imposed by others that leads to devaluation and discrimination. The second is from a consumer advocate named Larry Fricks. What people believe about mental illness may be more disabling than the illness itself. At the core of stigma is the belief that our thought process is broken. So talk to me a little bit about, why does the stigma exist, and what are these two experts when they're talking about it? Maybe tell me their thought process.
So, I think there are some parts of the behavioral health, mental health, and substance use community who have great concerns about use of the word stigma, and I just want to get that out there, that there are concerns about that. But I think it's important for us to use the word because it's kind of a gathering point. Everyone can really understand what we're talking about. The research community uses the word stigma, so I think that needs to be the starting point. However, you can't talk about stigma without talking about discrimination. So we can't just stay on this focus of stigma and that mark and that label, because there's very little we can do about that. What we really need to get at are the behaviors and the laws and the structural forms of discrimination that are associated with stigma. The two are inextricably linked. So we need to recognize that and remember that that's important. Also, in the definition that you put up, it says it's a mark placed by others. So the person who experiences the stigma and the discrimination, that is placed on them. That's not something that they do to themselves. And I think, so when we're looking at ways to reduce stigma and discrimination, it needs to come from the outside. We need to clean that up so that it doesn't occur to the person. Then finally, this whole, issue that Larry Fricks mentions is, and I've heard this from so many people with the lived experience of mental illness, that the illnesses can be incredibly painful. It can be very, very difficult illnesses. But what happens to them as a result of those illnesses and those experiences are far more painful. And so we have a lot of work to do in that area as well.
Okay, and there's different forms of stigma, isn't that right? I mean, can you tell me different forms of stigma: public, self, courtesy, structural, and label avoidance? I mean, what are those?
So by, putting up a slide like this, it helps us to understand just labeling, and using the word stigma doesn't tell the whole story. We have to unpackage it. We have to peel back the layers in order to really address it. We have to see, what are we dealing with here? And stigma comes in many forms. It can come from just simply labeling somebody. She has a mental illness. Or it could be placed on people associated with people with mental illnesses, like family members and friends. But one that we don't talk about enough, that I think especially reporters who are interacting with people with mental illnesses need to understand, is that there's self-stigma. If you've been labeled with an illness your whole life, you internalize that and you begin to stigmatize yourself. And sometimes, at least according to people I know who are living with this, that's the hardest one to deal with of all. But then finally, structural forms of discrimination, structural forms of stigma are things like policies and practices, like lack of funding for mental health issues. As I said earlier, as many people will die by suicide this year as women who die by breast cancer. But the amount of resources we provide to mental illness, to depression, to treating early in this country aren't there. So we're still combating these structures that hold us back in terms of finding research and treatments, doing research and finding treatments so that people can live productive and meaningful lives in their communities.
Okay, so the connection between stigma and discrimination. I mean, can you maybe talk a little bit more about that? I mean, if there's a social stigma out there, I mean, what is the impact on policymakers or other cultural forces that have an impact on how people are dealing with it?
So, let me give you an example. So, a journalist who we have worked with closely through our fellowship program looked at the justice system in the state of Oklahoma and the level of people incarcerated with mental illnesses. I think that is a prime example of, stigma leading to discrimination. All too often in this country, we take people who have, experienced substance use problems, that certainly our disease group, as well as other conditions like bipolar disorder, where they may have an event with psychosis. And instead of giving them the treatments and supports they need to deal with those issues, we put them into prison. And they live through prison sentences where they have very little access to services. I think that's another form. That to me is a great example of the stigma leading to discrimination. Any other health conditions, we couldn't even imagine that. But for some reason, it's okay to incarcerate them and label them as moral failures because of their health condition.
Okay. So we have a question from Twitter. Question for Rebecca. Rebecca, what advice would you give to journalists who have editors who are more old school on covering mental illness? And also, the same questioner asks a follow-up. I've heard some editors be skeptical that people first language, which we're actually going to be talking about in a little bit, and people first language and guidelines on covering suicide are important. So how do you deal with the old school editors, the editors who don't see a problem with putting method of suicide in headline, for example?
So, in situations like that, and that's why we have programs like the one we're having today at National Press Foundation, as well as the fellowship program at the Carter Center, is, this is a long process. It takes a long time to change attitudes and practices. And so, we start with training. Ultimately, I think, as we grow and understand the issues, people will move into those leadership positions, and so they're more informed. But in terms of dealing with it more immediately, I think it's important to take the approach of, one, there are AP-style standards now for mental health reporting. that is important to point out. So at least, you have the standards. There's also the Carter Center's reporting guide for behavioral health, offering up those guides as support for your position. But then thirdly, I think it's important to use data. This is not just about hurting people's feelings or being PC, but we have strong data to support this as a public health issue, really beginning to talk about the prevalence of these conditions, in terms of how much we need to report on the topic, I think is important. Also showing exemplars of great reporting. There are awards like the Mattingly Award now here at National Press Foundation that could be shown and saying, this is important. This is the way they're doing business now in terms of award-winning reporting, and encourage it that way.
Okay, so you brought up the AP guidelines. So let's talk about those. The Associated Press Style Book is the Bible in most newsrooms. I teach my students, if it's addressed in the AP Style Book, that's just the way we do it. So the AP now has a long entry on reporting on mental illness, and we're showing it up on the screen. But it touches on many of the things that we've already been talking about or will talk about today. Some of the AP guidelines do not describe an individual as mentally ill unless it's clearly pertinent to a story and the diagnosis is properly sourced. Mental illness is a general term. Use specific conditions and disorders when possible. Do not use derogatory terms such as insane, crazy, nuts, or deranged unless they're part of a quotation and that's essential to the story. So my usage of roasted nuts was part of our discussion, so it's appropriate. Do not assume mental illness is a factor in violent crime. Avoid descriptions that connote pity, such as afflicted with or suffers from. And avoid interpreting common behavior to many people, such as sadness or anger, that are as symptoms of mental illness. And finally, avoid using mental health terms to describe non-health issues, such as saying an event was schizophrenic, when you mean to say it was disjointed or unorganized, and you use the word schizophrenic, which is a mental term. So the AP guidelines, do you know how long those were in development? How long have they been there?
I don't know how long they were in development, but I do know that they were, I believe they were published in May of 2013. So they're about 4 years old. And certainly they were kind of in development in the period shortly after Sandy Hook and the Newtown shootings. I just want to pull out one of those to really emphasize to the reporters who may be watching this. And as I read those guidelines, the thing that I just don't see enough of when I'm looking at reporting is this whole idea of using the person with the lived experience of mental illness as an expert in the story. Who better to describe what it's like to have a manic episode? Who better to describe what it's like to be involuntarily committed to a mental health hospital? We need to find ways to really engage and talk to people who have had these experiences. I think all too often there's this fear of, what if I say the wrong thing and trigger them? What if they're unstable, and can I really use them? There's all these concerns, and I think it's just it takes very sophisticated reporting to spend the time to really get to know people, really talk through these very sensitive issues, but they are some of the best experts out there. Instead of working around them and having the people around them talk about it, go directly to them as an expert.
Okay. So I have another question from Twitter I'd like to throw at you. How do you feel about the term criminally insane? Is it an outdated or derogatory term?
Well, criminally insane is a legal term. Okay. It is not a mental health diagnosis. So I think, again, it's really important to draw the distinction between and really educate yourself about mental health diagnoses. And we have those in the media guide, the Carter Center media guide, a good list, a description. So again, going back to just as you would with any other medical diagnosis, go back and use the appropriate terminology, and then also understand what's the legal terminology used by the justice system.
Okay, so tell me a little bit more, your book there, the Carter Center. First of all, tell me a little bit about the Carter Center's mental health program and your fellowship program for journalists, and then tell me what resources you guys have in terms of guidebooks for journalists.
Sure. So the Carter Center Mental Health Program has been in existence for a few decades. It's developed by former U.S. First Lady Rosalynn Carter. Shortly after President and Mrs. Carter left the White House, they developed the Carter Center, which most people know. It's a nonprofit organization working in peace and health around the world. The Carter Center Mental Health Program is a health program within the Carter Center, and we work really in two areas. We work on public policy and we work on stigma reduction. And Mrs. Carter and her advisors, when really looking at how do we dispel the myths and misconceptions about mental illnesses, really thought through the idea of let's engage the media and help them better understand these issues so that we don't have the headlines like roasted nuts and perpetuate stereotypes and myths, but instead help them better understand what we know, that treatment is available, that recovery is possible, that policies, it's important to implement policies that encourage access to services and to treatment. Early intervention is important. So they developed the Rosalynn Carter Fellowships for mental health journalism 21 years ago. The program has now awarded almost 200 journalists year-long fellowships to study a major topic around mental illness or substance use, with the whole focus of doing a project that will ultimately be printed, aired, a multimedia package to really improve the reporting around these issues. It comes with a $10,000 stipend. So, in a kind of an expansion of that, we've partnered with National Press Foundation on a workshop today looking at what's at stake for mental health, kind of in the policy world, but we also, as I indicated earlier, have a media guide that we've developed to really help journalists understand some of the issues we've talked about today, as well as a list of resources that are at their fingertips, because we know, when we've had these horrible events, like a mass shooting, or like the events of this weekend with a suicide, they need something right at their fingertips that they can go to, but also go to their editors and say, hey, this is the state of the art, this is best practice in reporting on these issues.
Okay, and so I want to show a couple of the pages from the guide. One of those is on the person-first language. Mm-hmm. Another is on common mental health conditions. So that gives journalists, the technical language for diagnoses, mm-hmm. and so you can tell different diseases mm-hmm. that all fall under the mental illness umbrella. Talk to me a little bit about the person-first language. I mean, what does that mean, and what's an example of how it might have been reported in the past and how you think it should be reported now? So person-first language. I think a lot of people consider when we bring this up that it's about it's about checking off that box and saying we're doing the politically correct thing. I want to back away just a little bit from that and help us see the bigger picture, that it's more about helping us recognize that we're all people first before conditions that either we currently have or we have experienced. For some reason, it has been okay up until now to make people their diagnosis. He's schizophrenic, the mentally ill. They're put in a box, that's who they are, and they're nothing else. It doesn't recognize that they're a mother, an employer, a baseball player, a lover. They're that diagnosis. Stop and consider, can you imagine that if somebody had cancer, we called them cancerous?
but for some reason it's okay to do that with mental illness. And so talking about person-first language is our way of saying, stop, let's talk about this like we talk about other health conditions, and that we're people first. It's about respect.
Okay. So I want to talk, as we said at the beginning, talk about some of the stories that get it right. So these are some examples of some journalism that you've come across. I think a couple of them came from your fellowship program. The first one is from Stars and Stripes, Banding Together to Fight and to Heal. And this is actually by a journalist named Martin Coos, who is one of our fellows in the past, and he was one of your fellows also, right? So tell me, what about this story resonated with you?
So I wanted to include this story for a couple of reasons. One, PTSD has had a lot of visibility in the press over the last decade. In fact, I think a lot of people are very familiar with it at this point, which, to me is really exciting, and some great progress has been made. But what Martin posed to us is he said, I want to go and kind of further down the line here, go all the way back to the beginning and see what can we do to prevent PTSD, or at least mitigate some of the worst symptoms of PTSD. So he proposed to go to Iraq and Afghanistan and sit with troops and explore this whole idea of present traumatic stress disorder. How do we deal with this when it occurs? When members of a group observed one of their colleagues die, what do we do at that point? And offered up some things that were being implemented by chaplains and psychiatrists on the ground in the field. And I thought it was a great way of showing, one, a different spin on that story, but two, offering up solutions, that there are programs available to really look at this on the front end. In addition, I think doing a story like this in Stars and Stripes, you're getting an audience that this is very relevant to, and can actually take it and run with it and do something about it.
Okay, let's go on to another story. This is from PBS. To help delinquent girls, programs aim to rehabilitate rather than incarcerate. So again, this is getting at solutions to the issue. So tell me a little bit about that story.
So just as I stated a little bit earlier, the incarceration issue really is it's an old practice. It's what we've done for hundreds of years related to mental illness. But this particular story is saying, stop, hold on. There are some behavioral health issues that we need to address, and we need to find different ways of addressing them so that people can go on and live in recovery and be meaningful members in their communities. Ultimately, engaging in their communities, employed, paying taxes, all the things that we want to do. And so this to me was an example of how you can do that in another form of media beyond print. Following stories, individual stories can be an incredibly powerful way of illustrating a larger point. I think one of the greatest challenges that reporters have when doing a story like that is actually finding somebody who's willing to go on the record, right, who's willing to show their face and tell the story. And my hope is that as we have more and more reporters doing this well, doing this right, more people with the experience will be able to be willing to take the risk and go and do it.
Okay. And one more story here. This is from the Atlanta Journal-Constitution. Mental health treatment for the uninsured has a heavy price. What's the story on that story?
So, we've had a few fellows over the years. Another fellow was in Oklahoma looking at the system. And I think, it's some really powerful ways to tell a mental health and substance use story is to look at the system and what's working and what isn't working, and expose flaws and gaps. And maybe, in some cases, abuses in the system. But with the right set of circumstances in the right communities, with the right leadership, reporting like this can ultimately push public awareness around an individual and stimulate public policy change. We've certainly seen that through our fellowship program in states like Oklahoma and states like Oregon, Washington State as well, where a really strong series of investigative stories can make a huge difference in the lives of real people with behavioral health conditions.
Okay, so we have another question from one of our viewers, Rebecca. What dialogue should pharmaceutical companies be having, and how should they address customers with mental illness?
Well, we're really here to talk about the press and
Right.
reporters, so I can't really speak to pharmaceutical companies and how they should approach the issue. I think, what's important is for journalists to have a really good understanding about what treatments are out there,
Okay.
what drugs are out there that are supporting recovery and supporting treatment, but I can't really speak to the pharmaceuticals role.
Okay, sure.
Mm-hmm.
So we do want to talk about some of the other resources that are out
Mhm.
there for journalists. We're going to show some of these resources out there, but I was hoping you could tell me a little bit about some of these institutions or these organizations if
Sure.
people aren't familiar with them. The DART Center. What exactly is the DART Center?
So the DART Center for Journalism and Trauma is a center that exists at Columbia University Journalism School. And the origins of the DART Center were around looking at specifically the needs of journalists who report on traumatic events or in traumatic environments, specifically war reporters, those reporting on natural disasters, as well as those reporting on crime. What I like, there's so much I like about the DART Center, and they have a lot of resources, and I encourage the reporters watching this to go on their website and check out the rich resources that they have there. But one specific thing I'd like to pull out is a lot of people don't think about it this way, but reporters are first responders.
Mm-hmm.
And for too long, they haven't been given the supports that traditional first responders have in terms of their own mental health, in terms of their own physical health. And the DART Center helps us to recognize that self-care for reporters reporting in traumatic events is really important. There's a high risk of PTSD, especially when you are in prolonged situations and exposed to a lot of gruesome, difficult settings, and they provide resources to those journalists. So I think that's important. And one thing, when I'm working with journalists who are reporting on mental health stories, sometimes they can be incredibly difficult. To sit with people for long periods of time and follow them for long periods of time to really get that story, self-care needs to be in lockstep with that work.
Okay. Reportingonsuicide.org. So this is getting at the issue that we opened the program with. Who's behind that group or that website?
So there's groups like reportingsuicide.org, but also the CDC and the Carter Center has it as well, and a group in Australia through their Beyond Blue campaign all recognize that the issue we started this discussion with is one of the most important issues to talk about when we talk about reporting on mental health. Suicidereporting.org provides a lot of resources in thinking about that very sensitive issue. And I imagine a lot of people watching this webcast have questions in their mind, very relevant questions about, well, shouldn't we report on the method that was used for suicide? And really talking about those discussions, having the standards to report on them, really important. So we wanted to include that specific website so there are some guidelines on that particular set of issues.
Okay. Well, I think we are out of time for our questions right now. We will put on the website for the National Press Foundation a list of the DART Center, the CDC, reportingонsuicide.org, and some other resources that journalists can use, including one vital data resource, the National Survey on Drug Use and Health. Great data that journalists can use to get at these issues. But for today, I want to thank you very much.
Thank you for having us. It's been a real pleasure, Chris.
Okay, and thank you for joining us today from the Evelyn Y. Davis Studios at the National Press Foundation, where we make good journalists better. Today we've heard from Rebecca Palpant Shimkets of the Carter Center's Mental Health Program. Find more webinars and reporting resources at nationalpress.org and follow us on Twitter @NatPress.